So major obstetric hemorrhage and anesthesia definition it is mainly based on the bleeding volume. So major obstetric hemorrhage is any kind of excessive bleeding related to pregnancy. Normally it is say grade 3, 1500 or more. It's called the major obstetric hemorrhage. And or it may be causing a fall of hemoglobin of more than 4 grams from the baseline. So that is also considered as a qualification, and or it may need more than 4 units of blood transfusion. So any one of them are the criteria to call an bleeding after a delivery during delivery is as an obstetric hemorrhage. Excess blood loss of 1500 ml or a fall in hemoglobin of more than 4 grams or a transfusion of more than 4 units of blood. And this may be happening during pregnancy, that is antenatally or intrapartum, during childbirth or postpartum. And bleeding typically occurs vaginally, but rarely it can happen inside the abdominal cavity also, as it happens in rupture uterus. And why vigilance is needed to detect major obstetric hemorrhage? The hemodynamic values are not useful for diagnosing MOH, as physiological changes associated with pregnancy mask it for a long time. That is the major issue with which we all miss the bus. So the hypovolemia, before it produces its changes as described in the grades of hemorrhage, that is it will happen little late. So by the time you recognize it, patient would have lost quite sufficient volume of blood. And the visual estimation of blood loss is often erroneous. So we try to underestimate because it is also mixed with the amniotic fluid. Or blood loss sometimes can be concealed internally or hidden in the drapes. So these are all the reasons why we have to be very vigilant about the amount of blood loss that is happening. Coming to the antepartum, 1/3 of this due to placental oppression, and another 1/3 placenta previa, another 1/3 is uterine rupture. Uterine rupture, you have to anticipate mainly if the patient had a previous cesarean and the wall of the uterus is weak. So it's a rare event, but it is more common with previous caesars. So you have to be very watchful if they are undergoing labor and then being taken up for cesarean. And classification and main causes of this, we can classify them antepartum, during delivery, postpartum, and local causes. So antepartum, as described again, placenta previa, abruption, and coagulopathies or uterine rupture. During delivery, laceration during vaginal delivery. And postpartum, majority uterine tony, atony, and placenta, various types, increta, percreta, or cervical lesions, and all these things. So you can just put a tabular column like this so that you can save a lot of time instead of writing sentences. And what are the complications of antepartum hemorrhage? The fetal complications are, there may be hypoxemia, so there may be premature delivery. If there is a concealed hemorrhage because of placental abruption, that may try to push the fetus because the cavity is getting filled up. And if it is a minute insidious slow bleeding, it may cause growth retardation or sometimes intrauterine death, congenital anomalies, and birth asphyxia. Maternal complications are acute hemorrhagic shock and its sequelae, may reason to go to acute kidney injury, premature labor, postpartum hemorrhage, retained placenta. All these things are complications which are listed here. And the causes of postpartum hemorrhage are commonly used as the mnemonic 4 P's, that is stone, which is the most common, trauma, tissue or retained placenta, and thrombin or coagulopathy. So to this they also add another T, that is whenever the hemorrhage is happening, do not wait. Try to transfer the patient to the theater. If it is a vaginal bleeding occurring in the labor ward, when the uterus is not contracting and bleeding is happening, apart from the 4 causes, make sure that the treatment for that is to transfer the patient to the theater, TT. So you remember the 5th T, that don't wait too long. And PPH is more commonly associated with placenta previa, multiple pregnancy, all these things again earlier given. Risk factors associated with the prevention are, first, again, this is a repetition of what is being told in the sentence form. So writing like this will be much more easier. What is the immediate plan for management? We recognize early warning signs. We establish basic non-invasive monitoring. Administer 100% oxygen. In case the patient is pregnant, we head down position. Call for appropriate help and feel. That is very, very important. And of course, establish large bore IV. Send blood for cross match if it has not been done earlier. But nowadays, majority of the women undergo blood grouping and return the antenatal period itself. Start rapid infusion of warm saline. So this is very, very important to prevent hypothermia. Even during the administration of crystalloids is very, very important. So start using crystalloids, 1.5 to 2 liters. Don't go beyond 2 liters to fill up the circulation. That will cause a dilution, and that will aid in or prolong the coagulation time and cause more bleeding. So if the blood pressure or parameters are not getting corrected with 2 liters, then that is an important indication that it should be corrected only with blood and not colloids or other things. And send blood for basic CBC, RFT, etc. coagulation parameters, and warmers and warming blankets again repeated to prevent hypothermia. In case of emergency, when before you are waiting for blood, O negative blood also can be given, just like in trauma patients. Aim is to maintain normovolemia, monitor hematocrit, urine output, and hemodynamics. Prompt treatment of coagulopathy if necessary, if present. Early planning of surgical intervention and conservative measurements. Further management depend upon the cause of hemorrhage. So treatment, monitoring hemoglobin and coagulation. These are the two important things that you have to remember. So preeclampsia, HELLP syndrome, all these things, they are causes of which can precipitate coagulopathy. So you must try to identify whether these things are present. And early coagulopathy associated with hemorrhage is caused by consumption of clotting factors and hemodilution secondary to use of crystalloids and colloids. These are the two things which are going to prolong the bleeding. So point of care monitors allow more timely estimation of transfusion requirements. What are the non-blood products? Hypothermia and acidosis significantly impair coagulation. That is why again and again keep the patient warm. Never allow them to become hypothermic. Prevent acidosis. All IV fluids must be warm. Hypoperfusion should be treated aggressively. Tranexamic acid, widely used in the management of hemorrhage in obstetric, in dose of 1 gram is given. Supposing the bleeding is continuing, you are given oxytocin, you are given other uterotonics, give tranexamic acid 1 gram over 10 minutes period, and you can repeat it after half an hour. So there is no harm. Again, after half an hour, you can give one more. And in many cases, this seems to have worked very well. And maintenance of calcium concentration during hemorrhage helps prevent coagulopathy. So 10 milliliters of 10% calcium chloride for every 4 units of packed red cells you are given should be a routine management. So the blood products, O negative, can be used if there is a delay in getting the blood. Excessive clear fluid should be avoided. This is a very important point. So don't cross 2 liters during your resuscitation. And increased use of electronic issue of blood enables. This is, of course, in Western countries, they are to minimize the time period in issuing the blood from the blood bank. Nowadays, they have this electronic issue of blood, which is done for all the mothers. They antenatally draw the blood, keep it cross-match and ready, and all the details are fed into the computer, and you can easily get the blood without delay. And the ratios of packed red blood cell to FFP is 1:1, and sometimes you may have to use platelet also as 1:1:1. And fibrinogen level is very, very vital for coagulation pathway. So in obstetric patient, it should be more than 2 grams per liter or 200 milligram per deciliter. Fibrinogen is present in FFP and cryoprecipitate in small volume in fibrinogen concentrate or prothrombin concentrate. So the smaller volume avoids overloading also. Cell salvage in obstetric practice has caused debate because it is mixed with the amniotic fluid. But nowadays they use a separate suction for amniotic fluid and collect the blood. And because it is being washed in saline, the fear of amniotic fluid embolism is not there. So they do uh, collect the blood and use it in cases of rare groups where the compatible blood may not be available. Activated factor 7A is a very debated treatment. It is quite expensive and it is not been proved to be quite successful in all cases. So what are the treatment goals of transfusion for massive hemorrhage? You must maintain a hematocrit of more than 30, that is 0.3, and platelet should be more than 10,000, 1 lakh. Fibrinogen should be more than 2 grams. Iodized calcium should be more than 1 millimole, that is almost 9 milligrams. And temperature of the patient should be more than 36 degrees. These are the 5 parameters which should be maintained to say that you have successfully resuscitated the patient. Hematocrit of more than 30, platelet of more than 1 lakh, fibrinogen more than 2, ionized calcium more than 1, and temperature 36. Now coming to the uterotonics which we use, syntocinon is there. Of course, all the effects of syntocinon are all given in all the books. It causes vascular smooth muscle relaxation, and bolus doses may cause sudden hypotension and a reflex tachycardia. So it is better that you give as a IV infusion, commonly given as 10 units per hour. Ergometrin was used when we were all postgraduates way back about 1970s, but now it is totally not used at all. And the carbopras is a third line uterotonic given by IM injection. It is not given IV, and it is contraindicated in asthmatics because it causes bronchospasm. So 250 micrograms IM may be given at 15-minute intervals to a maximum of 2 milligrams. And misoprostol is active via rectal, sublingual, and oral routes, and it can be given IV also. And the dose is 400 microgram to 1 milligram. It is inexpensive, does not need refrigeration, and therefore useful in resource away from the hospital settings. So even in small centers, you can use that. Now, the anesthetic technique for, as I said, anticipated or unanticipated major obstetric hemorrhage, regional anesthesia is associated with lead blood loss for elective cesarean for placenta previa also. If major blood loss is anticipated, patients should be counseled about the possibility of rapid conversion of regional to general anesthesia. So you have to tell the patient beforehand, you have a placenta previa, I am now starting with the spinal, you will be awake, and if there is any need, I may have to put you to sleep. So that must be always told to the patient. And if the patient is potentially difficult airway, straight away go for a general anesthesia. Do not attempt spinal at all if you anticipate difficult airway. And in an emergency with a cardiovascularly unstable patient, you have to go straight for general anesthesia. So the two indications for GA are potential difficult airway, and second is patient who is hemodynamically unstable. And in such cases, arterial and central venous cannulations will allow more intense monitoring. So you can do repeat blood sampling for ABG, and you can also infuse vasopressors. And so surgical and other interventions are intrauterine balloon tapenade, uterine compression sutures, intra-arterial balloon occlusion and arterial embolization, which are all done under local. Intra-uterine balloon tapenade also, just you can insert it like a Foley's balloon and try to tapenade that. And pelvic vessel ligation will require when already the abdomen is open. But if it is done in a patient who is bleeding vaginally after a normal vaginal delivery, then you may require a abdominal exploration. For that, you may have to go for a GA because already she will be hemodynamically unstable. So internal iliac artery or uterine artery ligation is done. And as Nikhil said, finally hysterectomy is the ultimate thing. But this becomes a very major issue, especially if the mother is a primey and that is the first child, and if the child is dead born and you do a hysterectomy, this will lead to a lot of litigation problems. So this is the ultimate step that if you want to save the mother, sometimes this may be the only solution. So it's a life-saving measure, should not be delayed in situation where hemorrhage is causing uncontrollable physiological instability. Okay, so these are the points that I thought I will share with you.